Dr. Mark Richardson. Dr. Richardson is the Director of Epilepsy Surgery at UPMC. He is an Associate Professor of Neurological Surgery at the University of Pittsburgh School of Medicine and specializes in comprehensive epilepsy surgery. Dr. Richardson, I'll turn it over to you.
Thank you, Allie, and thanks to NeuroPace for hosting the webinar. Thanks to everyone for joining. We're going to talk about advanced treatment options for epilepsy, so modern options. And let's just jump right in. We're going to try to make this interactive. So if anyone has questions, please type them in and send them to Allie, and she'll forward them along, and we can have a discussion in real time through the messages. So please don't hesitate to interrupt me. Okay, so let's start with the basic slides. I think it's always good to cover this. We have some people sometimes that join that maybe don't know this information or haven't seen it clearly. So what is drug-resistant epilepsy? Someone has drug-resistant epilepsy if they've failed 2 anti-seizure medications. So that just means not even in combination. If you tried one, it didn't stop seizures, and you tried another for an appropriate amount of time, and you're still having seizures. And that's any seizures at all, and that includes ARAs, which are seizures. Sometimes people don't know that, but the ARA is the start of a seizure or the start of a spread of a seizure. So it's just 2 medications. It's not 3, it's not 5 or 16. So there are a lot of people in the US who have this problem, about 1/3 of patients with epilepsy at least. And now the reason that we really harp on this, and the reason that the American Association of Neurology has guidelines to help guide people towards experienced epilepsy centers, is that the chance that a 3rd medication is going to stop seizures is less than 5%. And this has now been shown in multiple studies. So, that unfortunately is the bad news. And many people or family of patients who are tuning in this evening have already seen the effects of this. And some people, maybe on their 4th medication, their 5th or 6th. And there's often a honeymoon period where there's a change in medication, things get better, but ultimately we know, statistically speaking, the chance of getting seizure control if someone has failed 2 medications is less than 5%. So that is the bad news. The good news is that in the over a decade now that I've been involved with epilepsy surgery, we've really seen a lot of things change in the field. And that's what we're going to talk about in the webinar tonight. And there are a lot of reasons, I think, to be hopeful. And certainly one of those reasons is the RNS device. But we're going to cover all surgical options. So what do you do if you or one of your family members is in the situation where 2 medications have already failed, or medications are controlling seizures okay, but side effects are so bad? And this is one thing that a lot of neurologists, I think, don't take into account, or family medicine doctors, that the medications take a real toll on people in a variety of different ways. And so it's not just about how many seizures are you having, it's about how do you feel, and are you able to do the things in your life that you really want to do. So if you're in this situation, the first thing you should do is find a comprehensive epilepsy center. And there's an organization called the National Association of Epilepsy Centers, which certifies programs based on their experience and what's offered there. And the sad thing is that of people who really should be seen in a comprehensive center, which is often at a university-affiliated hospital, but doesn't have to be, only 1 of 5 patients with refractory medication are seen. So that means 80% of people with epilepsy who potentially could benefit from real expertise in epilepsy management never talk to someone who's an expert. And that's the reason that this webinar series exists. Oh, so I wanted to ask, we're going to try a poll, and if everyone who's listening could participate, And if you, or if you're tuning in for a family member, if you or your family member has or is currently treated in a comprehensive epilepsy center, let us know. And I think Allie's going to set up that poll, so you'll see. Oh, there it is. Are you being evaluated? Yes, no, and I don't know, because you may not know. So I think this will stay up as I advance the slide. And Allie, maybe just keep this up for a little while. People can think about this. Let's see.
Perfect, thank you.
I can move it, great. All right, or actually, can I shut this down? I don't know, I'm gonna put it off to the side here. Okay, so what we want to talk about is a modern epilepsy evaluation. So, I see a lot of patients in clinic who maybe were evaluated as children, the seizures calmed down a bit, maybe they went away, seizures came back, they go back to the children's hospital, there's no new workups really done. Eventually they make it into a comprehensive evaluation, and they realize that things aren't the same as they were 5 years ago, let alone 10 years or 15 years. So the goal of a modern epilepsy evaluation is a normal life. It's to try to return the ability for people with epilepsy to live a normal life. And the first and foremost goal is stopping seizures. If we can't do that, we have a lot more tools than we used to be able to reduce the amount of seizures, improve quality of life. That's very safe. With a lot less side effects and morbidity than you would expect from surgery. So University of Pittsburgh Medical Center has stories like this. On our website, you can look them up. You can go to other comprehensive epilepsy centers and find the same thing. And I would certainly encourage you to do that if you're wondering, well, what type of people would have epilepsy surgery and what happens to them? You can read about these people. Okay, so we won't take a poll on this, but one thing I want you to consider through the presentation is whether you have had a modern epilepsy evaluation. And the other question is, ideally, how do you want your epilepsy treatment to change your life? And there are different ways to ask this question, but basically it means, if there's one thing that you could change about your epilepsy and how it affects your life, what would it be? And then the question is there potentially a treatment option that would allow you to do that? Okay, so let's talk about a modern evaluation. So anyone who has seizures that occur on medication, or anyone who's had seizures, whether or not they're currently occurring or not, and who has had an abnormal MRI, where there was a finding on the MRI. It could be a low-grade brain tumor, it could be a vascular malformation, it could be something that no one was sure what it was, but it was a lesion and it seemed to relate to the epilepsy. Anyone that meets these criteria should be referred into a comprehensive epilepsy center, where you'll undergo an inpatient stay in the epilepsy monitoring unit. And this is a setting where medications are reduced. You stay for several days, sometimes a week or more, until seizures are captured. And no one likes to do this. No one likes to have seizures. No one likes to come off their medication. And no one likes to be trapped in the hospital. But the fact is, that is the best way to collect the most important information to begin to characterize your seizures, with an ultimate goal of figuring out, can we either remove the part of the brain that seizures are coming from safely? Can we ablate it with a minimally invasive approach like laser thermal ablation? Or can we stimulate that area directly with a brain neuromodulation device? So let me just take you through a schematic that shows how the epilepsy workup works in a comprehensive epilepsy center. So someone comes in for the inpatient stay in the epilepsy monitoring unit, and either at that time or shortly thereafter, they get a number of non-invasive studies. So that includes an MRI that, if at all possible, should be a high resolution MRI, like a 3T or 3 Tesla MRI. The patient is hooked up to scalp EEG and has 24/7 monitoring by video, typically 2 video cameras. And so a seizure is captured on video and by the scalp EEG. And then the epilepsy team will evaluate that to get as much information about where the seizure is coming from as possible. Neuropsychological evaluation is also helpful in determining what effects seizures have had on the brain already. And this can help us figure out where seizures are coming from. There's something called a SPECT study, which is a metabolic scan that's done as a CT scan, basically. And then at our institution and at other places, there's an effort to very early on in the evaluation process put the patient in touch with the neurosurgeon, someone who actually operates on the brain and is very comfortable talking about this. And we find that this is the best way to introduce patients to the idea of surgery, whether or not we know they're candidates. But the fact is that when you get to this stage, when you're going through the epilepsy monitoring unit, the chance that you would benefit from surgery of some type is extremely high. And so we just try to initiate a discussion early on about the possibilities, give patients a chance to meet the surgeon, to try to address common concerns, fear of surgery, the idea that this stuff sounds crazy, people's fear of dying or becoming vegetables, which is almost never happens, never happens in our practice at least. So we try to address these concerns head on and early. Okay, patients are discussed at Epilepsy Surgery Conference. This is a multidisciplinary conference where the imaging is evaluated, brain imaging, neuropsychology, the EEG, any other functional imaging studies. You might get something called a MEG scan, which is a different way to look at electrical activity in the brain, or a PET scan, which is another type of metabolic scan. And then there are one of 3 basic outcomes. The group will feel that there's a seizure coming from one spot, that's a focal seizure, and it may be that that area is pinpointed based on just the scalp EEG and the MRI and other non-invasive methods, in which case patient will be referred for neurosurgical consultation. It's possible the group would think that there's a seizure coming from one spot, but we're not sure where it's coming from. And there could be a variety of reasons. The MRI might look normal. The MRI might look abnormal, but doesn't match what's seen on the EEG. And so further evaluation is needed. Or it could be very clear at that point that the seizure is not coming from one spot, it's coming from 2, or it's coming from a larger network, or it's starting everywhere all the time. At least it seems that way. And that is called a generalized seizure. Okay, so let's talk about this again just briefly. So I mentioned the idea of talking to a neurosurgeon early on in the course of the workup. Of course, I am biased because I am a surgeon, but we've started something at UPMC called SAFE counseling, which obviously is meant to highlight the idea that the surgery is generally much safer than people imagine. So we call this surgical alternatives for epilepsy. And the bottom line is that talking to a surgeon does not mean operating. It doesn't mean that you want a brain surgery. It just means that you're taking full advantage of the opportunity to learn about all the potential types of treatment for epilepsy and how that might at some point be relevant to your care. Okay, you can read about this. Here's the website. You can look at this later. So let's talk about this. Okay, here we are at this stage. We've talked about it. And then the question is, what happens next? So traditionally, the one treatment has been to do what's called an open craniotomy. So that means temporarily moving the skin out of the way and the bone out of the way and the dura out of the way, the covering of the brain, seeing the brain, using a microscope usually to move parts out of the way to get to an area and remove that area if it can be determined that the seizure's coming from that spot. And we would do that after this initial step only if we have a focal seizure and we're really sure that seizure is coming from a focal spot in the brain. We have good evidence to lead us right to resection. Now we have another minimally invasive option, which is to use laser heat, and we can do this in the MRI in real time, and we can put a probe in and see an area of the brain heat up, which is essentially the same thing as removing that part. It's called ablation. You can do this in limited areas in the brain, so it's not indicated for all types of surgery that we would typically do open, but especially in cases of temporal lobe epilepsy where the seizure is coming from the inside part of the temporal lobe called the hippocampus, we're increasingly using this as a first option. It may be, I'd say half of the patients that we operate on really need a diagnostic surgery first. So in this case, we cannot go right to a treatment surgery. We need more information because the data was inconclusive. Either it looks like multifocal seizures or it looks like probably it's coming from one spot, we're just not sure where it is. And so in this case, we put electrodes in the brain or on the brain to figure out with greater certainty where seizures are coming from. Ultimate goal is to send people in one of these directions. And the reason I'm talking about resection surgery or ablation surgery first is that this is the only way we currently know to permanently stop seizures or to cure someone's epilepsy, and that is to take out the part of the brain or disconnect it through ablation. If we can't do that, then the next best alternative, and a lot of people fall into this category, is responsive neurostimulation. This is implanting a device in the brain that senses when seizures are happening and in response delivers mild, small amounts of electrical current that disrupt seizure activity. And we think also disrupt the kind of background network activity that sets people up to have seizures. And then really, I think, at least in our practice now, a last resort is vagal nerve stimulation. This treats seizures indirectly by placing a device in the vagal nerve in the neck, which has a kind of global effect on brain activity. We don't know how it works. This is a good option for people when it becomes the last option. But there's really, we feel better efficacy with these options before. Okay, so we'll move through this quickly. And again, don't hesitate to let Allie know if there are questions. You can type them in. So intracranial monitoring is the diagnostic surgery I mentioned. There are two different ways to do this. The goal is the same in both. It's to find where the seizure starts. And now most comprehensive epilepsy centers offer both. So this is the traditional way to do this in North America. This is a lateral skull x-ray. So from the side, and you can see this is someone who's been implanted with this large grid of 64 different recording locations and some other strip electrodes and maybe some depth electrodes into the brain, some around the frontal lobe here. This is very good for mapping seizure activity that starts on the surface of the brain. We know a lot of seizures start from deeper regions of the brain, and in that case, we have something called STEREO-EEG or SEIZURE. And this, in terms of comfort for the patient, is minimally invasive. It doesn't require a large opening to see the brain and place electrodes on the brain like we do with grids and strips. But we can use robotic assistance and special software to plan these trajectories, and through very tiny openings in the skin and the bone, we can place electrodes into the brain to record seizures from deeper structures. This is a short video that just takes you through what this looks like in the operating room with a robotic arm and the planning software. And we planned out different trajectories here. And you'll see that the robotic arm guides a holder in place that's then used to make a small opening in the skin and skull. Patients completely asleep under general anesthesia. The robotic arm does not do anything to the patient. It's just a holder, but it is very precisely located over the spot where we want to make the entry. And you can see now an electrode's going to be threaded in. And we do this multiple times, sometimes on both sides of the brain. and it's very effective. So the advantage of this procedure is that there's no large incision. It's more comfortable for the patient. Targets deeper brain regions. Can be used really anywhere in the brain. It's great for reevaluating failed surgeries. So, treated a number of patients who have had grid surgeries and sometimes resections in the past. There's a guess or a hypothesis about where seizures are still coming from, and they've been told, or they think, well, there's no way I would go through that again, which is completely understandable. But STEREO-EEG is a great option because you do not have to open everything up again, and you can potentially, even in very difficult cases, for instance, map a network into which the RNS system could be implanted, or if it's very obvious where residual seizure focus is, an additional surgery or a laser ablation. So basically options that don't require opening everything up again. Okay, and that's the last 2 points in this slide.
Dr. Richardson, we had one question come in.
Great.
So this question is from Barb, who says, my daughter has a baclofen pump that would not allow her to have an MRI. Would surgery still be an option?
That is a great question. Yes, I think there are a number of things to consider, but I absolutely wouldn't give up on it. For instance, if there were MRIs that existed before the baclofen pump was placed, I think it would depend on scalp EEG and what that had shown. And I wouldn't rule it out. These really complex cases, I think this is a good example of something that should be addressed probably in an in-person meeting at a comprehensive epilepsy center, but certainly wouldn't rule it out just online. I think the important thing is to go in and talk about it. And that can be applied to whatever someone's situation is. If you're not sure, there's always someone willing to talk to you about it in a comprehensive epilepsy center that treats a lot of patients. And thank you for that question, Barb. So I wanted to take you quickly through these treatment options. First is resection surgery. And I'm not going to spend time on this because maybe many in the audience have heard about resection surgery, and surgeons harp on this all the time as having really low morbidity, which means does not have a lot of side effects. I would classically ask patients in the clinic, what do you think the chances that you'll come out and your talking will be affected or your motor function? And they'll say 50% or something that is to me outrageous, because it really what we talk about in terms of permanent deficit from resection surgery is usually on the order of 3% or less. And the chance for real improvements is extremely high if all the data matches up for resection surgery. So I think one of the keys to understanding this is wherever you're being evaluated, if you've been told that you're a candidate for resection surgery and you're really hesitant about this, best thing to do would be to talk to patients who've had that type of surgery. And certainly in our practice, we keep a list of these patients, and they're available to be called. Let's talk about laser thermal ablation. So in some cases, it does make sense to do a focal ablation first, even if the next step after that, if it doesn't work, is maybe to do a more formal open surgery. And I'll just show you an image of how this works. So this is the hippocampus. On this side, this white stuff is called the choroid plexus. It's supposed to be white, but the rest of the structure is supposed to look like this. Looks like kind of a little fish. Here it's been ablated, so there was a track through the back of the brain. And the rest of the brain around is completely normal. Here it's bright because that's where the heat has affected this tissue, and it's basically like removing it. And this is a short video that shows you in the software. While we do this in the MRI, we see this line that shows us where the heat is. In this case, it's been overlaid with the post-op MRI. that shows the outline of where the ablation is. So you can see, the rest of the brain, and the temporal lobe is untouched, but we can go in and essentially take out the part that's causing seizures. And in order to do this, we often have done a diagnostic surgery first to prove to ourselves and the patient that seizures are coming from this particular structure. And now moving on to RNS. So even though those first two options stand the best chance for seizure freedom or curing epilepsy, there are many patients that either don't want to undergo those procedures or are not candidates because the seizure focus has not been mapped definitively enough, or we know that the seizure is coming from more than one spot. And so in that case, the RNS device is really the best option. It's a great option. It's a true example of personalized medicine, where this is called the pulse generator. And it sits in this tray in the skull, and then there's some electrodes that either lie on the brain or very thin electrodes that go into the brain that record seizure activity. That signal goes to the device. The device makes a decision about whether or not to deliver electrical current, and that comes back out. And you can see overall it's pretty small, and patients, when they have this implanted, no one knows it's in there. If you really push, you might feel some bumps from it, but for the most part, you don't know it's there. And the outcome data is very good, I think, from the use of this device. And more importantly, it's improving as we learn more about the right signals to record and the right way to program the device. And so we're really kind of accelerating in our ability to use the device to help people more quickly. So the long-term data is more than 70% seizure reduction on average at 7 years. This does currently improve over time, so it doesn't look like that in the first year. But importantly, almost a third of patients have had through some period at least 6 months with no seizure at all. So in a group of people that have a really hard time getting seizures under control with medication, this is very good. We think over time that it's going to get much better. And one of the reasons is because of all of this personalized data that's being recorded for a given person that is very specific to that person's brain. And this data is essentially stored forever and can be analyzed and reanalyzed until basically we get it right in terms of how the programming should work. Patients have reported kind of all of these things as a result of seizure reduction of the device. We think probably modulating background seizure network activity. These are the basic qualifications. So currently, a device is not approved for kids. That may change in the future, not too distant future, but currently that would be an off-label use of the device. We've talked about having to try more than 2 medications, and the device is not really meant to be used in generalized epilepsy, although we have done that in our practice. It's FDA approved for 1 or 2 seizure foci. And so the common conditions are people that have epilepsy coming from both temporal lobes, seizures that come from language area of the brain, from a movement area of the brain, areas that we cannot take out. Or if another surgery didn't work, or the patient doesn't want another type of surgery. This is a little bit more about the procedure. The simulator itself, even though it looks in the picture like it's laying on the brain, it's in the skull. And then there are these thin wires that either go into the brain or this very thin type of flexible plastic that just lays on the brain. Most of our patients go home the next day. Sometimes they'll stay two or 3 days. But it's a pretty straightforward procedure. There's training involved. The patient gets a laptop that comes with the device and downloads data to the device daily and uploads at least once a week that data into the cloud, basically a web base storage system that clinicians in our epilepsy clinic can access. We can look at the data, analyze it, and make decisions about how to specifically program the device to work in a given patient. So there's a new battery or pulse generator that was just released, and that is estimated to double the battery life from an average of 4 years to an average of 8 years. So that's a really big deal. Basically means now you get this thing implanted, you don't have to worry about it for several years in terms of whether you need a surgery to replace the battery. I've mentioned this, it's just a cartoon to show this, and I have some photos in the next slide. So the idea is to monitor seizures where they start in the brain and to stop them in the same place. There's this remote wand which reads information from the device, and then that's connected to a laptop. And then you do have to have an internet connection at home or access to an internet connection that's reliable in order to share that data with your clinical team, who are going to review that, and then they review it through this patient data management system. We've had patients ask about analyzing their own data or looking at their own data. And I would say that even though that sounds like it'd be very useful, the way we think about this is like any other type of medical information. It's highly complex, and it's really something that you leave up to the clinicians to analyze and make treatment decisions on. So these are photos from the Pittsburgh. One of the local Pittsburgh papers for one of our patients who was implanted with the device. This is her actual x-ray. So you can see it's there with leads. She had bitemporal epilepsy, so seizures coming from both sides, both temporal lobes. Here she's using the wand at home. She's showing that. Here's her laptop. And here she is in the clinic with Dr. Urban, one of our epilepsy neurologists, reviewing this information. And I wanted to just share this, which I think is typical for a lot of patients we see, whether they get RNS treatment or some other type of treatment that they've never heard of before. So in her case, she's having 3 to 4 seizures a week. And now, although she still has seizures, they're a lot less frequent. They don't last as long. She feels better. And most importantly, I think this device, or really any decision that's made to move forward with a modern evaluation, allows patients to gain some kind of control over their epilepsy, whereas otherwise it's just so frustrating because there's a real lack of control. You never know when you're going to have a seizure. And this is just constantly wears on people. And so I think the device does empower people to learn about their epilepsy, certainly empowers clinicians in terms of data that we can use to help people. Just mentioned that this seems to work in all brain regions where it's been tried. Some results are variable, but on average, it's pretty good. 60 to 70% responder rate and median changes. And again, this is in the setting of over now a decade of use of the device. And we're really constantly improving our ability to have better outcomes even that are shown here. But there's not a part of the brain where we would not consider using this device. Now the idea of having a device in your head does not sound minimally invasive to people. That's understandable. But from the surgeon's perspective, it's a minimally invasive surgery that has very, very low risk, essentially 1% risk of causing bleeding in the brain by passing an electrode through. Okay, so that's it, with the exception that I'm going to switch the screen I'm sharing and just show you one other thing that I think is helpful, and that's on the NeuroPace website. and it's patient stories. So Allie, are you seeing the right screen now? Does everyone see this?
Yes, we can see the patient stories page now.
Great. Good. So I would encourage people to have a look at this. And, I think it's good, even if, someone's not a candidate for the NeuroPace device, don't like the idea of device, still interesting to read people's stories and kind of see what they went through to get to the spot that they did. And this is Nancy, one of our patients. She was our second patient to get the device. And I just wanted to point out a couple things that she says that, are common themes. Tried a dozen different drugs. And the idea that someone should have to try so many medications before they get to a treatment option is really outside of standard of care in the current stage of what we know about epilepsy and epilepsy treatment. And then this is I think a common refrain from people after any successful epilepsy surgery, but even after responding to the RNS, where Nancy still has seizures, and she's had some periods that are better and some periods that are worse. But overall, she feels like there's a big improvement in her quality of life. And so I think if you read through these stories, it might be helpful. And also the thing to point out is that there is a program called the Ambassador Program where you can talk to patients who've had this device. And I think wherever you are in your own epilepsy center, most programs have a system where you can talk to patients who've had the type of surgery that you might be recommended for, that you might be considering. So I'd absolutely encourage you to reach out to other people with epilepsy. Okay, that's it. So I'm happy to take any questions. My email address is available on the University of Pittsburgh Neurosurgery website. So if you Google my name and neurosurgery, you can find that. You're welcome to email me any questions afterwards, but also happy to take any questions now.
Thank you so much, Dr. Richardson. As a reminder to everyone, you can still submit questions through the Q&A panel at the bottom of your screen or through the chat on the bottom of your screen as well. So we had a couple more questions come in for you. The first question is, how long does it take to go back to work after the RNS surgery?
That is a great question. The incision will heal very well, almost completely within 2 weeks. We've had patients go back to work after a week. You'll see that a general recommendation for time to take off from work after any brain surgery is a month. And so we're always happy to, allow people that much time or longer if they need it. But I think the best practical advice is 2 weeks. Depends on what your job is.
Thank you. The next question is, if I already have the VNS and I still have seizures, could I be a candidate for the RNS?
This is a great question because there's so many people who were implanted with VNS who may not have had the opportunity to have a full evaluation or had a full evaluation, but it was many years ago. And yes is the answer. VNS does not rule you out from any of the potential surgery options that we talked about, and certainly does not rule you out for RNS.
Thank you.
Let me mention one, sorry, Allie, sorry, one other thing about that that's a real common one about VNS. So some people have been told, because it used to be that when you had a VNS, you couldn't get an MRI. That is no longer true. So if anyone's told you you cannot have an MRI because you have VNS, that's incorrect. There are certain parameters that have to be followed, but you can have that. It is also possible to remove a VNS. And so we do this all the time for different reasons. It's not always possible to remove the coils around the nerve, but one does not have to do that if the idea is to take the device out and not use it. The rest of the components are very easy to remove. It's just a question of whether the electrodes around the nerve are too scarred to take those out.
Thank you. The next question is, how long does it take to determine what treatment is the best for you?
These are really good questions. Depends on the stage that you'd, let's say, enter an evaluation at comprehensive epilepsy center. But I'd say a few months is what we try to do. Sometimes it takes longer, sometimes it's faster. And it's like anything else. If you're an advocate for yourself and you have really good communication or following up, you can get through the process in a couple months. And then there are things like, in terms of when you'd get the treatment, someone's surgery schedule. But we really, once people enter the system, they're presented at our epilepsy conference after having gone through the epilepsy monitoring unit evaluation. We really try to have an answer with the follow-up testing done within a couple months. Some cases are more complex than others. It can be hard to schedule various things, but the key is just advocate for yourself. And this really should be on the order of months, not longer than that. And sometimes it's faster.
Thank you. We have one more question. Just a reminder to everyone, you can keep submitting questions. So the next question is, does everyone need intracranial monitoring before getting the RNS?
What a great question. No. There's an open question in the field about whether everyone should. Is this, are we passing up an opportunity to get information that's useful for either where to implant the RNS or what settings might be used? So this is an area that's under active investigation. It's a question that we're looking at in my own lab. But short answer is no. So traditionally in our program, we have done intracranial monitoring before implanting the RNS, but we've had patients who were able to skip that step. So that may be dependent on the philosophy of a given center. There are other places that are more liberal about just implanting, but it really, the answer is it depends on your epilepsy and what information is available. And it's important, I think, that the individual person is considered in the context of their information. But short answer is no, it's not necessary in some cases.
Thank you. We had one more question come in, which is, could you talk more about cases where you've implanted RNS in people with generalized seizures?
Sure. So let me just mention that this is off-label use, and there are we get requests from patients who, let's say, otherwise we would put in a vagal nerve stimulator, which, by the way, that's also off-label use, but that's really the most common use is really in generalized epilepsy. They are worried about the what they perceive as poor efficacy from the VNS, or maybe they are a singer, or they're dependent on their voice. They don't want to take the chance of side effects, or they just don't like the idea of that, and tired of medications and are holding a job and able to interact with the device and willing to take a shot on something that is experimental, to be clear. That's why it's not FDA approved. But we have had success trying that in at least one patient so far. So I think that's something that really is, again, experimental and would need to be discussed on a case-by-case basis.
Thank you. So those are all the questions that I've seen come in. Dr. Richardson, do you have anything else you'd like to say?
Well, these are the best questions I've received after any webinar, so I really appreciate people's attention, and I hope this was helpful. Anyone who didn't get a chance to ask a question, please feel free to follow up later. And thank you, Allie, for organizing this, and thanks to NeuroPace for hosting the event.
Of course, thank you so much, and thank you to everyone for attending today's webinar.
Allie, I'm going to interrupt. Allie, I'm sorry. I'm going to interrupt with one thing.
Oh, please, go ahead.
I have to give a plug for one of our patients. If those are tuning in from around Pittsburgh, note that September 7th, it's Friday night at the West End Overlook. A patient of ours is doing a kickoff fundraising event for her foundation called Enduring Epilepsy. And so if you Google that, Enduring Epilepsy, you'll find that information. And I encourage you to come out and check out what's happening there, get some more information, and have a great time with a good view of Pittsburgh.
That's awesome. Thank you.
Thank you.
So thank you, everyone, for attending today's webinar. You will receive a follow-up email with a link to view a recording of today's webinar. So if you have more questions and want to watch it again, you will be able to do that. NeuroPace is the sponsor of this epilepsy webinar series. You can find more information on the RNS system as a treatment option at neuropace.com. This concludes today's event. On behalf of UPMC, Dr. Richardson, and NeuroPace, thank you all for joining us, and have a great rest of your evening.